They talk about central sensitization.
All right, next slide, Katie, please. All right, so everybody, if you want to, turn your videos on, that'd be great too. But here is what is upcoming. Dr. Cole and Dr. Olives next week talking about the emergency department and getting Suboxone started in the emergency department or buprenorphine products. This has been a huge push, and Hennepin has done a great job with that. So you can kind of see other things coming up. Next slide.
Yeah, remember
there. Like I said, sorry, go for it.
There's free CME. And again, Heather already said it once, turning that video on makes it way more fun for Isaac. So feel free to do that. Get that free CME. Remember, Katie will send you something out right away afterwards. So please fill that out. Next slide.
And if anyone wants any help with anything, whatever it might be, please us or Aaron. Aaron's email's on there or her cell phone number. So never hesitate.
All right. And again, I believe the manual is going to be up fairly quickly now, any day. But this is a nice place to go for all the information that's all posted. It's all free. You can download stuff. So feel free to go to CORE. That is a nice place to get more information.
All right. So with that, we will welcome back Isaac. I always say your last name wrong, Marsfulik, talking about central sensitization. I absolutely love this topic, and Isaac has presented this or a version of this a couple different times for us now, but it is so huge, especially in this world of trying to come up with different pain alternatives to opioids and, the different mentality of chronic pain and all that. So Isaac, if you want to say a few more things about yourself, that'd be great. Otherwise, take it away.
Sure. Thanks for having me back, and thanks for everybody for tuning in. So as was mentioned, this is the third time that I'm giving the talk here for Echo, and every time I got to do something a little bit different. And so this one, hopefully will be a little bit more focused on sort of what actually is happening in the clinic room when you're meeting that person for the first time. How can you get through that and sort of get to a place where you can start focusing on treatment and moving forward with helping people. The previous talk, and I don't know if they're recorded, it might be recorded not, really went into a lot on the evidence for treatment. So all the medications and all the non-medication stuff and the evidence behind that. So if you're kind of looking more for specific, what does the literature say about stuff, that would be more that talk. This is a little bit more kind of nuts and bolts. What are you doing in the visit with the person? And so just to kind of cue that up, I don't have an objective slide. And I was told to have that. We made objectives, but I didn't put it in my guy. So I don't know if Katie has that, or
I can put them in the chat here.
Okay. Yeah. If you don't mind, put it in the chat. I think for CME or something, maybe we need that. So, okay. So we better make sure we do that. Goodness. So, all right, I'm going to share my screen.
It makes everything a surprise if we don't know them though.
Yeah, that's true. Okay. So let's try this. Can everybody see my slides and hear me okay?
Yes.
Good. All right. So no financial things. So we'll start out just talking about kind of what central sensitization is and a little bit about the biology behind that before we jump into more of the clinical stuff here. So you can read the definition there, but essentially it's just this amplification of sensory signals that happen in the brain and spinal cord that results in a number of different kind of overlapping conditions. And this is a really great slide. This was kind of the first time I saw it. This was, I think, in 2008 or 2012, but these overlapping conditions. And so you have a sensitized nervous system and then kind of the things that happen related to that, with fibromyalgia being maybe the one that people most recognize. The functional gastrointestinal disorders, that'd be like our IBS, irritable bowel syndrome stuff. Multiple chemical sensitivity, that's sensitivities to medications. A lot of people are really sensitive to medications, perfumes, lotions, and then maybe just more general sensitivity, lights, sounds. Weather is a really big one for people as well. The interstitial cystitis, or just kind of chronic sort of pelvic pain, can be related to this. Pain with intercourse is a really big complaint that patients will have who have a sensitized system here. And then this is just an example of what maybe a pain diagram looks like as people come in. And this is, an example where just everything is really sensitive. There's a bunch of stuff all over the diagram of where things hurt. And then we added some numbers in to just really let you know how bad the pain is. And so, and this really gets, obviously this is maybe some catastrophizing that's going on, but it's also really getting at the experience that people have of that. This is really, really unbearable and really, really impactful. And also that I want you to take me seriously. This is how bad it is. Okay. There's some other conditions associated with this as well. So about 80% of people with fibromyalgia also have symptomatic hypermobility. So there's some connection there. POTS or oftentimes instead of specifically going through POTS stuff, I'll maybe ask about, do you ever feel like you're going to pass out or feel lightheaded or that you're going to black out, or kind of changing positions is difficult because of feeling lightheaded. And you'll have a lot of people who notice that. And then if people are hypermobile, they tend to be much more likely to have anxiety and panic attacks. Small fiber neuropathy is another one that's a really big one. Numbness in the fingers and toes is one of the most frequent complaints patients have who go through with this. There is a gene sometimes that can be responsible for this. A lot of times we don't know what causes it, but it's definitely a big concern that people have. You get the EMG and it comes back normal. And so the small fiber neuropathy is often a diagnosis that will come up with that. Mast cell activation syndrome. I think I have maybe 2 patients that have this. And so I don't see it as much, probably at a big academic center. You'd see that at more. And you can just see that there's, again, a lot of overlapping relationships between the different conditions that we saw with this. So, again, these can be separate things, right? You can just get a headache and not have a sensitized nervous system. But if you have a sensitized nervous system with headaches and symptoms consistent with fibromyalgia and restless legs, et cetera, then you're starting to put it all together. So what's going on biologically? And I'll just say a lot is going on biologically. We're not going to spend a ton of time on this, but we will spend some time on this. And so one of the most important things to understand about pain is that we're all wired a little differently depending on what we get from mom and dad. So just like height, some people are short and some people are really tall, and then there's a group in the middle. Some people are not very sensitive to pain. They get a stimuli and just don't notice it too much. And other people get that same stimuli and they really feel it. And then there's kind of a group in the middle. And that's just the normal distribution, people without medical conditions or issues. It's just how the nervous system's natural variability and pain sensitivity goes. And then there's things that can really shift that system one way or to the other. And probably the biggest one is the adverse childhood events, which we've talked about a bit on ECHO over a number of talks. And this can be trauma with a big T, physical abuse, sexual abuse, severe neglect. This can be trauma with a little t. Mom's working 3 jobs and never home. And so I never know when mom's going to be home. And I'm just kind of in a constant state of stress, or everything's great with mom and dad, but I go outside, I don't feel safe in my community. And I'm always wondering if I'm going to get hurt. And there can be a bunch of other variations. So if someone comes in and they say, well, I haven't had any trauma as a kid, if you dig a little bit deeper, you may find that there's some more little t stuff that might be part of that. Poor sleep is a big one. You take healthy college kids, you deprive them of sleep for 2 days, and they develop widespread pain similar to fibromyalgia. Most of us have had a night where we didn't sleep well and the next day just felt achy and uncomfortable. So we know sleep helps regulate things as well. The conditioning, if you're like me through COVID and didn't keep up on your conditioning, now when I start trying to do stuff, it just hurts more versus when I was working out more regularly. And then viral illnesses is another big one. So Epstein-Barr virus is one that's implicated. There's certain viral illnesses that if you get them, you're much more likely to get IBS symptoms after that. And then COVID, we've sort of got this long COVID where we're still figuring out stuff, but a lot of similar symptoms as to central sensitization for people who have sort of the post-COVID problems. So more stuff about what's going on biologically. If you take a bunch of stress and you put it on to nociceptors, or the machinery that helps us sense pain in our body, they will start responding for longer and longer periods of time. And so we know that if we're in stressful states, there is physical changes to our pain reception system that happens. And then neuroinflammation, and I talk a lot about this with my patients as well. Again, if we have this interaction between our immune system and our nervous system. So if our immune system gets fired up, either viral illnesses, if we're having stressful states, and that interacts with our nervous system, we're going to have changes with our glial cells, the NMDA receptor, and these wide dynamic range neurons, which are these special neurons, in particular in the spinal cord, that change how they signal over time to sort of continue to signal. There's a phenomenon called wind up, where once the nerve gets going, it sort of just keeps going. And all of those are implicated in this sort of change in how the nervous system functions. And then there can be genetic changes as well. And so for some people, they just don't metabolize the stress hormones, the catecholamines as well. And so they get these prolonged states of stress going on, which again interacts with their nervous system, which then leads to sensitization and the widespread sort of symptoms that people feel. This is a slide that's sort of busy, but it also tries to encompass everything. So we have some type of insult, something goes on that happens, and we get sort of issues with that: nerve injury, tissue injury, immune system activation, a bunch of changes, that the neuroinflammation, and then that interacts with what was going on, our genetic factors, what's going on in our environment, where we are psychologically, and can either prime stuff or lead to a transition to chronic painful states or these overlapping conditions. And so this is a working model. There's still a lot more that we'd like to understand about this, but I think this does a good job of summing up where we're at in our understanding of this. So connection to abuse, we just talked about. If you have a bunch of stressful things going on and it interacts with your nervous system, how you experience things is going to be different, and that bores out in the evidence. So 2/3 of women referred to this one GI clinic when they looked, had a history of physical or sexual abuse. Your odds of fibromyalgia are significantly more likely, much more likely to develop abdominal pain and GI problems with a history of sexual abuse. And of course, rape, an incredibly traumatic experience, leads to really high odds for both GI and fibromyalgia issues. So we talked a lot about the biological parts, or at least in some sense, the biology of what's going on that's leading to the sensitization. And then that interacts with other things going on, which is our prior experiences. So if I've burned my hand on the stove previously, and now I get burned again, and I get flashbacks of what's going on, that previous traumatic experience, my pain experience is going to be a lot different than someone who hasn't had that. Attention and expectation are big ones. There was a lady that I did a consult for before she went to surgery, and I told her she was going to have pain after her back surgery. And when I saw her post-op, I said, "How are your pains doing?" And she says, "Well, it's not too bad. I have a little bit of pain in my back, but you said that would be normal." And it turned out she had a huge epidural hematoma that was compressing like her cord, that should be incredibly painful, but because she thought she was just going to have pain after surgery, it wasn't that big of a deal to her. And so expectations and attention play a huge role in our pain experience. Where we're at with our mood can as well, on top of just biologically what's happening with our nervous system. This is a kind of classic example of how we explain the concepts of what's going on. So if we have a stimuli that causes pain, we kind of feel it for a while, and then eventually we start feeling pain until we have a high level of pain. When someone has a sensitized nervous system, they start feeling pain at less stimuli. We call that allodynia, so a non-painful stimulus that's causing pain. And then hyperalgesia, which just means something that typically wasn't very painful is now really, really painful. And these are really some of the hallmarks of what people experience with sensitization. And this is a study where they did it. It was just in action. And so if you inject hypertonic saline, a painful solution, into the tibialis anterior, depending on sort of what's going on for you, you have a very different experience with that pain. And in one of my previous talks, I had these really cute little mouse models that showed how the dendrites in the spinal cord start growing and connecting with other dendrites around them that then lead to more widespread mapping in people as they have more sensitization. And that's sort of what's going on in these cases. The autonomic nervous system is another part of this. I feel like if I'm giving a talk, I always have to talk about this. And most people understand the fight or flight, the sympathetic nervous system. And then we have really two parts to our parasympathetic nervous system. We have the one where we're sort of grounded, engaged, and this is really our sort of social connection system. And then we have the one that's a little bit more like can happen if we get really shut down. So people who dissociate, kind of depressed, hopeless. So a lot of times we really focus a lot on how do we turn down our fight or flight response, right? The anxiety and anger issues. But sometimes people actually are really turned off in sort of, like I said, more or less in a dissociation spot or numbed out. We have to really activate them to get them going. And so this is just something where people will oscillate a lot between boom and bust or fight or flight and shut down when they're dealing with central sensitization. And really interestingly is that we can have set point changes. So if there's a stressful event, I might get really dysregulated. Kurt might not get very dysregulated. But if there's changes in that system where my set point is shifted, maybe Kurt's case, it gets moved up and up and up to now he's just in a chronic state of threat instead of having the ability and flexibility to tolerate more, that set point gets changed so that there's less tolerance for that. And that happens over the course of time and exposure to stressful conditions. So I was going to spend the rest of the time moving into the more clinical approach, and then we should have time for kind of questions or talking about any cases or concerns people have. So when I have a patient come in and I'm scanning through my list, there's a lot of signs on there that can lead me to at least start thinking about, is central sensitization something I'm thinking about for this person? And I really do think about it as central sensitization because I just don't run into people who have just fibromyalgia without jaw pain or headaches or IBS symptoms or something like that. It's really a combination of most of those sort of conditions that we talked about. And what we want to do is move from, I have, 50 things wrong with me and no one can figure it out, to, oh, my nervous system is really sensitive and that's why I'm experiencing this. And that makes sense. And now we can start moving towards treatment. So the problem list is one thing that's really helpful. It just can often tell you right on the list if they've had diagnosis of a number of things that can be there. If you have people fill out paperwork and they do a review of systems, there's a lot of information there. Or like the pain diagram that I showed previously, those can all be cues that there may be something going on there. And then you just really want to steer the ship. So if someone comes in for, this was really just on Monday, I had a woman come in. Or was it last week? Anyway, recently I had a woman come in. She was in for neck pain, and I started asking her about her neck pain. And then she very quickly gets off into all these things that are going on and that are wrong with her. And she just has this whole story that she really wants to tell me about, all the things she's had problems with. No one can figure out what's going on, et cetera. And I just said, basically what I've written out here is that you got a lot going on, and I think I might know what's going on and how I can help you. I just have some questions that I need to ask you to make sure that we can sort this out. And so we put a little hook in there that, hey, you might know what's going on. And now we're starting to direct the visit into something more helpful rather than just a kind of feeling overwhelmed about all the symptoms that someone might bring to you. And then oftentimes it gets off track again because we start talking about, well, do you have headaches or other issues? And now we get going again. And so it's just a lot of redirecting as far as that's really important for me to hear. I also need to ask you about these other things. I really think I can help you feel better. I really think I know what's going on that's causing your pain. And I'd like to be able to talk about that. And so we kind of get there. On the flip side, if someone comes in and they really just want to talk about their neck pain, then that's fine. And maybe they're not ready to talk about a more in-depth conversation as far as what's going on overall. I do like to plant seeds for that, though, because oftentimes the treatments haven't worked because we haven't addressed the nervous system and put the complaint that they have in context with that. And so if I say, great, let's talk about your neck. If at some point you want to talk about the reason why you're having these other symptoms or why things haven't worked so well with those other problems you're having, I'd be happy to set up another visit. And so I just plant a seed that, hey, there's more that can be done to be worked on. And often that's really necessary if we're going to try to really move the person forward. And then once I kind of quickly, with either the problem list or what they're talking about, I quickly move into asking them about this to really sort out how much is actually going on. And what's helpful about this is you get really good information as far as what the symptoms are, but also the person starts getting that you understand them. It's like, wow, how did you know to ask about that my belly was a problem? Or yeah, I have had really painful periods. I didn't think to talk about that or mention that. And so there can be a lot of buy-in as far as that. You understand what their situation is like, which makes it a lot easier for moving forward to treatment. I almost always ask, where do you hold anxiety in your body? This is a nice one to then focus on treatment in the future. And all of us can probably think about where we hold anxiety in our body. A lot of people, their shoulders, some people clench. I'm more of a clencher. If it's really emotional, sometimes people maybe more in their heart or in their belly. But that can be sort of a tie-in then. I have really bad, neck pain. My neck hurts all the time. Where do you hold anxiety in your body? Oh, I keep it up in my neck. Okay, well, just something to think about and gives us some space to move forward for treatment. So pretty quickly, I move into the symptoms here. And then once we've gone through and looked at all the symptoms, I take a second to think about what other things might be causing the problem. On the bottom here, they had listed in this site that I got this from, this chronic fatigue, which I think is more a part of the central sensitization versus its own separate condition. I'm sure people could argue with me on that, but the fatigue and the other sensitization stuff goes hand in hand. So often I don't know that I've seen someone with chronic fatigue that hasn't had some of those other things going on. But there can be other conditions that do kind of cause problems, and you want to have those on your radar. If you work with patients enough, it'll be pretty clear that something different's going on when they're complaining about multiple sclerosis versus the sensitization. For me, most of the time, by the time people get to me, they are either been worked up by rheumatology or have had good workup with their primary doctor or have seen neurology. So there's not a lot of further testing to do. If someone hasn't had workup and they have some family history of autoimmune stuff, or they complain about some swelling things that I'm just not so sure of, I'll send them to rheumatology and just be clear that I just want to rule out autoimmune disease. I'm managing the chronic pain stuff. That's not for you to do, but I just need to make sure they don't have something else going on. And that can be pretty helpful then to sort of steer the person again back to, oh, okay, well, it's not these things, then maybe we'll buy into trying some other ways of treatment. And then once I've kind of gone through the list, and I feel pretty confident about the diagnosis, I'll talk to the patient. And I will say with my slides, so the very slides with the overlapping conditions, I will show that. So I pull up this PowerPoint probably a half a dozen times a week, and I go through a few slides with the patient. And I think it's really, really helpful for them. In particular, the slide with the overlapping conditions, they see themselves. I don't know how many times patients say, that's me, or that's totally what I got going on. It just really clicks for them that this is a issue that really is kind of all the things they have going on is just part of a kind of bigger issue going on. And that can be really helpful for them. I explained sensitization, and I'll go through an example of that in just a second. And then that pain doesn't mean damage. And that's a really important piece of this. One of the first things that I want to work towards is for people to start being able to trust their bodies and reducing their anxiety about what's going on with them. And so if every time they feel something in their body, they're worried about a cancer or something else, that was literally my patient's concern last week, is that every time she felt some new thing in her body that, she had a history of cancer, did the cancer spread? Is there something going on? So a lot of vigilance and a lot of anxiety about that. And so we want to start working towards what is kind of typical symptoms that happen with a nervous system that's sensitized. And then what is something that's not related to that, and that maybe needs a different approach. And then I'm always telling them that if you're not sure about something, give me a call and we'll figure it out, because I'm there with them to help them learn how to figure out what's going on with their nervous system. When they're feeling really fatigued, does it mean that they're anemic, or is it just part of their nervous system that's kind of flared up at that time? And as people get better at being able to judge that, their anxiety goes down and there's a lot less healthcare utilization that happens. And so I think it's really our job to try to help people understand what they can expect as far as their symptoms, and then start guiding them as to what is related to their nervous system and what isn't related to their nervous system. So here again, it's just that one. I almost always share this one when I'm talking to patients. And again, this one really resonates with people. And then I draw this out a lot. This is, again, from the talk a couple of weeks ago, but just gets at, for our nervous system, if we kind of pinch, we feel sensation. And then if we get enough pressure stimuli, we actually feel pain, which is a warning. And then if we press enough, we get damage, and we actually cause tissue damage. We have a nervous system that's sensitive. We get some sensation, but very quickly we start feeling pain. So it's like the alarm is going off much, much more quickly, but we still need the same stimuli to actually cause tissue damage. So just having pain doesn't mean that we're causing damage or injuring ourselves. And we want to start messaging that so people can get moving again, can reduce some of the guarding that they might have. And this can be a really important sort of concept for people as they're working through this. And I talk about what success looks like. And people who have a sensitive nervous system, they are going to be sensitive even with the treatments. We can improve things with treatments, but they will likely be sensitized and deal with it over the course of their lives. Just like people manage diabetes or heart disease or any other chronic condition, you have to manage this as well. And sometimes things are really going to flare up despite doing everything right. And other times there's going to be better times. But at the end of the day, we want to drop the needle in 3 months, 6 months, a year, and just say, hey, overall, things are better than where they were. The amount of pain reduction tends to be relatively limited despite lots and lots of different treatments out there. Occasionally we get some home runs and we're always excited about that. But regardless of the pain treatment, if we get about 30% improvement in the pain, that's really, really good. But the amount of suffering, the amount of disability, the amount of change in life roles, all of those things can really be modulated with good treatment. And so we have discussions about that. And this is also to get at that if you're having a bad day or things flaring up, it doesn't mean you're doing anything wrong. It's just the nature of how this goes. So as we move into a little bit more of the treatment planning, the therapeutic relationship, I'm a huge therapeutic relationship person. I think that's our most important and most powerful tool in helping our patients feel better and move forward. And so I talked a little bit about attachment previously. I think attachment's a really important concept to understand and can really help you understand why people do what they do in relationship with one another. These are a few things I say when I see patients. The probably most important thing is just being really consistent, a solid and safe place for them to have treatment. You create a space for them to do the hard work of healing, but they really need you to be able to lean on if they're struggling with something, and you just need to be there. And so there's things you can say. I'm sure everybody has their thing that they say to their patients that can be helpful, and just whatever works for you. But these are a few of the things that just help people know that, hey, I'm here for them. Oh yeah, I almost always say I'm looking forward to you feeling better when they leave the visit. You set expectations. Goals for treatment at this. Not necessarily at the first visit. If we have time, lots of times the first visit is we got to get a lot of information, make sure we're on the same page that we're going to be focused on central sensitization as a treatment. And then I might say for the next visit, I really want you to come up with 3 goals for our treatment for us to work on, because you talked about a lot of things that really bother you. And I just want to know what the most important things are for us to work on. And maybe that's better sleep. Maybe that's pain reduction. Maybe it's less flare-ups. Maybe it's less anxiety at work. Or, I really want to get off this medication that makes me feel icky, whatever it is. But if we set up the goals, then the patient has a lot of skin in the game then, right? They said, hey, this is the most important thing for us to work on. And then we can focus on that and move forward. And then we reevaluate. You said headaches were the most important thing for us to work on. How are we doing on your headaches? And goals can change and shift, but when we have so many things going on, we want to really try to get focused on what's the most important thing for the person. Then also with things, if you're not sure where we're at, it's sort of like, well, what are we doing here, right? You said headaches were the most important thing, and I recommended these medicines, which you didn't want to take. And I wanted you to go to physical therapy, and that didn't work. And so I'm just kind of wondering, where are we at here? Because you said that was really important. And that's what I wanted to help you with. What's changed with that? So we can kind of keep moving the conversation forward. Resolving the diagnostic quest. That's another important thing, I think, is our job. If people are coming to with this, most of the time they've had a lot of workup by the time they get to me. Maybe in your practice, they haven't had as much workup. And so there is some more workup to do. Again, we talked a little bit about the mimics previously, but we really want to figure out, when I present the information about central sensitization and I say, I think this is what's going on. If the person buys in, then great. Then we can just move forward with treatment. If they don't buy in and they say, I really think something else is going on, I need to know XYZ, I need MRI or this test or whatever, then we really have to have a conversation there. And maybe after they talk to you, you feel, well, that seems reasonable. Let's check into that. But as we do more testing, it tends to get more invasive and more expensive. And we have to think about the risks and benefits for that. And so that's, I think, something that's just a really important piece of this. Lots of times it's the validation that something's going on is what the person wants. And so I might really try to validate that. I really believe you have pain. I think there's a real biological reason that's going on, that you have the pain that you're having. If we could see your nervous system, we would see it looks very different than someone who's not experiencing what you're experiencing. Someone has an amputation, everybody says, oh my gosh, they got an amputation. No wonder things are different for that person. They can't see your nervous system. So it makes it really, really difficult. But I believe you have really bad pain. And I believe there's some things we can do to help you feel better. And so we really want to try to do that. If someone is just really pushing for some other kind of diagnostic thing, then we're not in agreement as to what we're going to be focused on for treatment, and treatment isn't going to work very well. So it's an important factor. Joining the resistance is just another technique that's used a lot because there's a lot of resistance out there. And we always start with whatever the experience is I believe your experience. So even if I disagree about what I think is the right next step for the person, like opioids, opioids are the only thing that ever worked for me. If I say, well, I don't think that's true, or they didn't really help you or whatever, or they're not the right medicine for you, we're just going to be starting at a place that's really difficult to bridge. If I say, I believe you, I believe when you say opioids are the only thing that worked, I believe of the things you've tried, that's the only thing that's worked. And I get that. I also think that there's safer options. And I really think there's some things you haven't tried that could help you feel better. And so we're just sort of joining and then sort of moving to the next thing. And so just want to be mindful if you're starting to feel like you're at odds with the person that you're working with, pay attention to the comments that they're making and what they're saying. And even if you sort of don't feel like those are the ways to go or the right thing, if you can join with it first before putting in your part, you'll find that it goes a lot easier. And then we have to address the elephants in the room. So if we agree on central sensitization and we're going to do the treatment and the person has an active alcohol use disorder, it's going to be pretty tough to move forward. And so we can do pain treatments in conjunction with treatments for substance abuse. And I think that's actually a really good model, but we won't be able to just treat the pain and then expect the substance use to go away or not be a problem anymore, or to not interfere with our treatment, right? If someone, can't connect with their body because they're disconnecting all the time by using substances, then it's really gonna be tough to move forward. Kind of really similar with the PTSD, anxiety, depression. Lots of times depression is related to pain. And sometimes if we do help with the pain, the depression can improve quite a bit. Anxiety, in my experience, has kind of not been that way. If someone has anxiety, usually there's an underlying anxiety disorder. If we help the pain, it may improve the anxiety some, but usually the anxiety really needs to get treated, similar to PTSD. And so I always think of pain treatments in conjunction with addressing the other things, not that if we do the pain, these other things will get better on their own. That is much less likely. And then skepticism and trust, these are huge things that need to get addressed. So if someone says, I don't really think that physical therapy is going to help me, and I'm not sure that I really want to do it, again, we're joined. We say, yeah, I get it. It hasn't worked for you very well in the past, and it's really flared things up. That's why I think we really need a very specific way of doing it so that it doesn't flare things up. And as you learn more of what you can do with your body, it'll be much easier to do the treatment. And then, of course, trust is a huge issue. If the patient doesn't trust you, then you're not going to get very far. A lot of times, again, this comes down to the validation piece, and believing that you got their best interests and know how to help them feel better. I did want to just talk about low-dose naltrexone because this almost always gets asked about when we talk about stuff. So this is the one medication that I'll touch on today. Again, the previous talk went through lots of medicines and the evidence for that. But the low-dose naltrexone, they found that it can be helpful for certain subgroups of people with fibromyalgia. There's not sure exactly how it works, glial cells or maybe opioid receptors. But my experience has been that too, is I have some people who respond very, very well to it, and then other people who like it enough to stay on it, and then plenty of people who don't feel like it helps, which is essentially every medicine in pain management. So it fits well with that. The nice thing is that it's really well tolerated and really, really safe. And so it's kind of a nice option for that. The low dose needs to be compounded, at least as far as I know as of today. And that can be cost prohibitive for a lot of people. There's usually not compounding covered by their insurance. And so what I do now is I'll just have them get the 50 milligram tabs, which people, maybe if you're treating like alcohol use disorder, are more familiar with that, but they're really inexpensive. And they just drop that into 50 milliliters of water or juice, dissolve it, and then they get a little syringe and they take 1 to 4 milliliters of that a day. And then after a week, they just make a new one. And so 4 tablets covers them for a month, which is incredibly inexpensive. And so sometimes people have a little bit of difficulty getting it down as far as how to do that. We try to give them a bunch of education on how to do that. But that's how I typically do it now versus trying to get the stuff compounded. If people have compounding coverage and they want it, then of course that's fine. And I think lastly is just pacing, which is another thing that I talk about really early on, which is just the idea of we do some activity and then we rest, we do some activity and then we rest versus boom and bust. We push through and then everything flares up and we're out of commission for 2 days and then we push through and flare. So the studies show that pacing decreases the amount of flare-ups by about 50% and the intensity of the flare-ups by 30%. So just by sort of pacing your time throughout the day, you can have a really significant impact on sort of what you're feeling as far as the flare-ups go. And so I think that's it. I wanted to leave some time for questions, and we didn't get into the weeds as much with the evidence for treatments as last time. So yeah, I'll take any questions. Thanks.
All right, Isaac. So my first question, just with, you just mentioned the naltrexone. Is there any harm in just doing the 50 milligrams versus, going to the low dose?
Yeah. So the thought is that, and there may be other people who know better about the mechanism here, but that it doesn't preferentially affect the glial and opioid receptors at the higher dosing versus at the lower dosing for some reason. And so that's why it's been sort of the low dosing is my understanding. And again, I will be the first to admit I don't know all the answers for that, but that's my understanding. And you can maybe have more side effects at the higher dosing. And a lot of times patients with the sensitization are pretty sensitive to meds. So the low dose just seems to be a good place to start. But yeah, if anybody else has more definitive information on that, I'd be glad to hear it.
Isaac, if you want to stop sharing your...
Yeah, I was just trying to figure out how to do that.
So my question would be this, is that often you see these patients, they've seen a lot of doctors. What's the common things? You've talked a lot about how you talk to these patients or the way you present and ask the right way to ask questions. What are the things that you hear that really irritate people? There's got to be those things that they come in and said, my doctor said. Wow.
Yeah, I bet everybody could probably add things, but the ones that I think it's mostly the validation, right? The pains in my head. That's probably the biggest thing, or they don't believe that I'm having pain. So that's probably the biggest thing, or that my condition doesn't exist. There's people that don't believe that fibromyalgia or other conditions like this exists. And clearly these people have really considerable distress and pain and issues related to this. So that's by far the biggest ones. Or that nobody wants to help me. Nobody wants to help me. That's another big one. I'm too complicated. I'm too messy for anybody to want to take care of me. And that gets, again, into some of the attachment stuff, right? I'm not worth it to take care of. And so that's another kind of piece that comes up a bit. But those would be my top ones.
So, sometimes these patients have, like you mentioned, been to several specialists, and sometimes the specialist will embrace it, own it, maybe give them a diagnosis of rheumatoid, even though it doesn't necessarily fit. And still they somehow end up with you. How, if a patient is 100% convinced they have this and they need to see this specialist, and then you're kind of coming at it from a different angle, do you ever have difficulty with that?
Yeah. So that does happen sometimes. And I can think of one person in particular that I thought had sensitization, and then she ended up having porphyria, which is, a pretty rare kind of thing. And she made it really clear. She wanted me to know that I got it wrong as far as the diagnosis goes. And so she still had sensitization symptoms, but that was kind of part of it. So if someone's really invested in a diagnosis, it's just really tough to move forward. And so oftentimes that quest needs to get resolved. So if there is somebody that I can send them to that I feel can help them resolve that without doing something really invasive or, $1 million workup or sending them to Mayo, that's the other thing, can you send me to Mayo to figure out what's going on? Then we have to do that, because if they really believe something else is going on, they're not going to buy into treatment to help them feel better. And we just say, well, if at any point you're ready that you want to try this other way of doing things, then I'm here for you to try to help with that. But sometimes you just can't force people into doing treatment. And so that's kind of how that goes. Most of the time, if we present it, like I said, in the way that I present it, usually there's a lot of buy-in with that because most people haven't gotten that information and they haven't had something that fits so well with what's going on for them.
Sure. Do you have luck communicating then with other specialists when it comes to some of this?
Sorry, communicating with other specialists?
Like, yeah, do you have communication or conversations ever with rheumatologists, for instance?
Yeah,
or
so
surgeons, or
so I have so usually if I'm connecting with somebody, for me, I always own the pain management piece and the central sensitization piece, but oftentimes I am sending them to get other things checked out. Like there may be a specific medicine that I want neurology to try for the headaches, or I'm sending them to the TMD clinic to work on the clenching or something like that. Or if I'm sending to rheumatology, I'm really clear about, I think this is what's going on. And I really just need you to say that's what's going on so that this person can move forward. Obviously, if they have some autoimmune disease that I'm missing, then great, let's figure that out. But most of the time, other specialists are really more than happy to help if they don't have to own it, right? Like if they don't have to own it. And so for me, it gets to be really pretty easy because I'm doing most of the heavy lifting as far as the treatment goes, but I just need them to sort of fill in that part so that the patient can buy in more to what we're doing.
I don't know if you see, Isaac, there in the chat, there's something about whether or not you're familiar with MALS, MALS. We had a patient who had many of the symptoms listed, was found to have MALS. Surgery fixed it. I don't know if you want to unmute, Kristen.
I did unmute. So it's median arcuate ligament syndrome. And it is something that I think there's a large group of mostly young adults as they're growing. I think there's some problems with, I don't know why, but there's the celiac ganglion gets kind of squished, whether it's during growth or something, but it presents a lot of what you're saying. So then I got a little worried that maybe you're overlooking these kids. There's a lot. So they have this, whether it's compression of the vessels or nerve irritation, it sounds a little bit more like wind up, but it gets really, really, really wound up. And the surgery does seem to fix the POTS and dysautonomia that come with it. So they kind of just shut that down. It really was ignored for a long time. And now it's come, I don't know why, but it's definitely become more common to hear about. Mm-hmm. But it is something that if you saw it, I'm afraid that you may say, oh, you have this, the wind up or the central sensitization, and maybe disregard and not know that there's an actual syndrome that could be causing a lot of that wind up, a lot of that, the other symptoms that come with it. So
yeah, there's also, I know a lot of research has been done looking at cervical stenosis too, as a possible cause for that too. And so I have looked at some of that. I guess I'll have to look into the MALS more too. Thanks for sharing that.
Sure.
Do you do much with kids? I'm sorry, Kurt, when she mentioned, this is the growing thing and more youth. Do you do much with youth or younger people?
No, all my patients, or not all, but the vast majority of my patients are probably 40 to 60 that I'm seeing for this. So I don't see anybody, under 18, just how our practice is. Not that people under 18 can't have some of this stuff, but my practice is I don't see that.
Yeah, my first comment would be now everybody on this call is going to be it could be porphyria. You ordering that test, it's I better check it for porphyria. But my other thought is, my question kind of is, do you look at success when you look at people that you think you have made success with? Is it ever that person who just says, so you're telling me it's just going to be like this, I just got to live with it, and I'm okay with that? As long as I know everything else is fine.
Yeah, I think the acceptance piece is helpful. And if people have a reason for why they feel the way that they do, that can be a lot easier. And so we move towards that. Acceptance is more sort of, this is how things are now. It's not saying that this is how I have to be forever or anything like that. But if you're kind of fighting against that this isn't me, even though that's what's going on. That's where a lot of distress happens for people. So people that in acceptance and commitment therapy is a really big thing in chronic pain. And that's something that a lot of people do and find helpful for them as they move through with stuff.
Anybody else got more? Go ahead.
So somehow early in my practice, I got a bunch of fibromyalgia patients. And so I've been using low dose naltrexone off and on for 20 plus years.
Oh, great.
In some patients, it works really well, but I think there's a reason it hasn't taken off. It's that, it doesn't work in everybody. Thank you for the tip about just mixing it in juice, because cost was an issue. My two questions, one about BUP and the effect on the kappa receptor. And so do you reach for that more often than some other things? And what about combining a low dose of buprenorphine with other opioids to prevent central sensitization?
So I don't use any opioids in central sensitization. And unless there's some other condition that kind of comes up with it, I think I would consider like a Butrans patch or something like that is a possibility. But there's a lot of other things that I do and use for people outside of that. So I don't have much experience with opioids for this. The guidelines are, kind of against using opioids for this outside of tramadol. And so I just don't use it very much. I don't know, have you used it much and had some success with it?
I've had a couple of patients who are not necessarily central sensitization, but like once you switch them off of opioids to BUP, I never get the calls for early refills like I was, and they're not.
Oh yeah. Just transitioning people from opioids to BUP, I do all the time. And that has been a huge game changer for me, but specific to this group of patients, I don't use that unless they came in with opioids already on board. And then we're kind of doing the opioid piece and the central sensitization piece. So.
All right. Other questions at all? I have one last question for you, Isaac, and I think we're just about out of time. Is there anything that you like when you're sitting with a patient that helps you predict whether they're going to be a patient that does well in the long run as opposed to decline? I mean, is it just a hunch, a feel, their attitude, anything that gives? Yeah.
I wish I could say yes. It's just, I get proven wrong so many times that I try to just really check my biases as best as I can. And so there's certain things that will come up where I feel like until that really gets addressed, it's going to be really tough for them to move forward, and maybe they're not willing to address it. And so that can be challenging. But I had a lady who, really was having a lot of symptoms, and she had a really, really intense job. And so, she took a leave and switched jobs. And in 6 months, she probably had like a 90% reduction in her symptoms because of just the change in sort of stress. And then also incorporating a bunch of different new kind of habits and self-care, and, was doing really, really great. And so, for her, when I first saw her, I was like, I don't know how this is going to get better because you got to work. And then, she made the change, and then she's doing amazing. So, that's just kind of like one example. So yeah, I don't have I don't know. I think I try to stay as open as I can when I see people, and just say, we're just going to do the best we can. And hopefully something clicks and it works. And it's really surprising at you create an environment for people that they then kind of figured out for themselves what really works best for them as you give them kind of different options and treatments and stuff. So, yeah.
Perfect. Any other questions before we let Isaac go? 2 great talks he's done for us in the last couple of months here. So this has just been fabulous. There being none, anything else, Heather?
I don't think so. Just thank you so much for coming back.
Sure. Yeah. Happy to do it. Thanks for having me.
All right, everybody. Back next week again, the ER, John Cole and Dr. Olive, and should be a good talk about some of the ER issues. And thanks again, Isaac. Absolutely fabulous talk. I think everybody agrees. So, all right. Have a good week, guys.